Well, you will recall that at the end of our last class, we were talking about how psychologists do assessment. And, you know, assessment, as I mentioned, is the most common activity that a psychologist engages in the sense that no matter what kind of intervention you're going to use, you start off by assessing the person. And I mentioned that that assessment, you know, will differ depending on the theoretical frame of reference of the person who's doing the interview, and depending on the reasons for why the interview is being conducted. And we had gotten to the point where I was saying to you, you know, there are some you know, pieces of information that obviously are more delicate than others. And I had mentioned often, you know, if someone is very insecure sexually, asking them questions about their sexual history can be very hard for that person. And I mentioned that, you know, an interesting phenomena to me in more modern days is the amount of anxiety that actually is created in people when you ask them about their income. That we have come to understand that in many ways, income for many people translates into a very important aspect of their self-concept. And for some people, it's highly correlated. It's like, if I am not making whatever my expectation is, then I am not the human being that I expect to be. And when you see that, you know, in an interview, that is when you see a person being very anxious when you ask them about their income, right away that gives you very important information. It tells you, for example, that the external rewards are very important to this person. It also tells you that the person has expectations that he or she is not yet meeting. And usually it says that that person's internal life is such that they think other people expect them to make more money than they're making, and that other people will respond differently to them depending on their income. Now, if that gets extreme enough, obviously that can be a very serious problem for a person. And especially if someone deludes themselves into thinking that that really is the issue, because what happens in such a situation is the person will never find that they have an income that causes people to respond the way they really want them to respond. So they never really integrate the fact that life is more complicated than that. Now, there are other important questions. You really want to determine if a person has social supports in their family. And that's really key, because especially if a person has certain symptoms. And the most common symptom, of course, you become concerned with is depression. If it is very serious, you want to know there are other people around to help the person. But it's also important if the presenting problem has to do with addiction to drugs or to alcohol. You find, you know, people who have support often can do better than people who are going to have to fight things all alone. So knowing what kind of social support there is becomes important. You also usually ask the person for some kind of self-description. You kind of want them to tell you who they see they are, what kind of a person this individual is, how effective perhaps they are in certain ways, depending on what the presenting problem is. But you want to get a sense, does this person think he or she is competent? Or does this person think, you know, he or she is isolated, not very talented, doesn't believe they can change things, versus somebody who feels optimistic about a lot of things, but they have a problem they just simply feel they can't deal with, and that's why they've come to see you. Those can be very different kinds of people. It's also important, of course, to get a person to describe what is it that they're seeking to change. And you want to see how they see the future. That is, do they come in with lots of motivation? They really think, if I really work on this, I will be able to overcome this. and I see myself overcoming it. If a person can say things like that, usually you're going to be able to be quite effective with them. If the person expresses a lot of ambivalence, I don't know if I can overcome this problem. If the person comes in and let's say their presenting problem is they want to overcome smoking, and they've tried several times, it hasn't worked, and they're pretty discouraged about it. You have to take them where they're at. That is, and you have to realize the person has made previous attempts. The fact that the person failed is important in some cases. It's not so important in other cases. What you want to recognize is the person is in the room, the person has come for help, and it's always, of course, easier to work with somebody who has made the decision themselves to come and ask you to help them versus they've been referred by someone else as a condition for them continuing in school or continuing their employment or staying out of jail or whatever. Often that makes it more difficult to work with someone. Also, the reason for an interview can determine what kind of data are gathered. For example, if the person is an abusive spouse or an abusive parent, then much information is sought, on the energy and the stimuli that cause a person to act in this way. And you want to know, like, what are the circumstances in the family that cause one spouse to get angry with another, or what is the situation in the family that causes a parent to start being aggressive towards their child? You want to get a lot of data to see what are those factors that seem to set this person off. Now, in contrast, if the person comes because they're depressed on the job, it's important to get a sense of what are the possibilities with this person. For example, is there any chance that this person can change jobs? I mean, if you determine that the person is probably not going to be successful on this job, they're over their head in the job, or the talents that they happen to possess are very poorly matched to what they're doing, you would want to know what are the chances of changing. Now, often when people come, there isn't much chance of them changing. I mean, they need to make an adjustment to the position they're in. So you need to begin to find out what is it that they do that causes them to be depressed, or what is it that they don't do, and what are the expectations of this particular job? Do they really understand the expectations? And are the expectations being set by someone else and they feel they can't live up to it? Or have they set the expectations themselves and then they can't live up to the expectations that they've set? Two very different situations if you're going to work with someone. And obviously it's much easier to work with someone if the expectations are internal to the person and you can begin to explore like why they need to set expectations that they can't achieve. Now, in assessing a person's problems, psychologists, being clinical scientists, are concerned with the reliability and the validity of the data that they gather. And these terms are most often used with psychological testing, but actually they apply in the same way to data you gather in an interview. In fact, these terms apply to data psychologists gather. Now, in seeking reliability, for example, there is a term called test-retest reliability. And it simply refers to whether you would get the same picture of a person if you examine them at a later time as examining them right now. In other words, do you have a more or less enduring picture of the person? It's not very helpful if your way of gathering data kind of captures somebody right in the here and now, but actually this isn't a very good picture of how they usually are. If that's the case, then the data you're gathering would not be considered very reliable. Now then, there's a term called inter-rater reliability. And now this refers to whether another interviewer would obtain a picture similar to the one you obtained. Now this is important as a means of obtaining a sense that your evaluation is similar to what other experts would have found as the problem for this person, so that it's not simply just that you are examining this person and you've gathered certain data and therefore you determine this person's problem, but actually if others who were as talented as you are and as skilled as you are interviewed the person, they would come up with similar conclusions. The same thing, obviously, when we get to tests, I'll mention it, but same thing applies to tests. Now, when you hear this, okay, now I interview the person, someone else interviews the person, someone else interviews the person, and we want each to have, fairly similar understandings of the person. Can you think of any context in which we find that inter-rater reliability is very low for psychologists and psychiatrists? It's in the newspapers all the time. What's the situation commonly used and talked about where so-called expert psychologists or expert psychiatrists failed to come to some kind of fairly unanimous agreement on a problem person? Sure, Mr. Oponi?
Could it be because of bias on the part of one, one psychologist over another, in terms of maybe looking for some certain kind of data as opposed to another psychologist looking for?
Okay, good point. Yes, bias can lead to this. That is, and your point, the person is already looking for something. Rather than interviewing the person to find out, the person goes in with a bias about what they're going to find out. So if you got two people who go in with different biases, sure, they may come out with different findings. That's certainly, and that's close to what the example I was looking for. Anyone think of the example? Sure.
Could it be like the controversy over repressed memories of childhood sexual trauma and stuff like that?
Okay, that's a good example because certainly there's lots of argument about that, and certainly if you go in with an attitude that it's going to be one way or the other, you might come out differently. But there's still an example. Suppose I tell you it comes in forensic psychology. Where is it that there's lots of argument? Expert what?
Expert witnesses?
Yes. Mr. Kim, very good. Expert witnesses. Isn't it interesting? You get 6 people coming into court, 6 experts. 3 of them come in and they say, this person is this way. They, of course, are 3 experts for the plaintiff. 3 other experts come in for the prosecution and they say the opposite. One expert says this person knew exactly what he or she was doing. The other expert comes in and says, this person's a very psychotic individual, very unclear in their thinking, emotionally labile, unable to pay attention to a lot of things, didn't recognize what they were doing. It's remarkable. But it's very important because it tells you that the interviewing process is not as scientific as we would like it to be. And as Mr. Opuni pointed out, if you go in with a bias, then that can create all kinds of problems. Now, there are people who are famous, actually, in the courts for only having seen everyone they have ever testified on, they've seen the same way. They've either seen the person as always, that is, they are a witness always for the defense, because they always find some reason for why this person should not be found guilty, or they're a witness for the prosecution and they always find another way. That is, they always find that this person absolutely should undergo capital punishment. It's utterly fascinating. And so now we're talking about a small number of people. I want to be clear that one doesn't want to look at the whole world of professional assessment and not recognize its importance because of a few people who come in and do assessments in a very biased way. But it does tell us that that assessment, is an arguable kind of activity. And so it becomes very important when you go in to go in very open-minded. It's very important that you not decide ahead of time what it is that's going to, what the outcome will be. Now, there are studies at the same time that have shown that, and the various time frames differ, but certainly there are studies that show that 90% of people who are given the responsibility for diagnosing a person will not, and if they diagnose the person after they've seen the individual for 5 minutes or less, that diagnosis will not change after they've seen them for an hour. That is, within a very brief period of time, skilled interviewers pretty much pick up on enough material that they know this person is either schizophrenic, or the person is manic depressive, or the person has a narcissistic personality disorder, or whatever it is that they're going to come up with. But it often doesn't take a person very long. So when you're skilled, one of the things that seems to happen is that you do recognize in a short period of time that people who are in a certain category seem to present themselves differently than people who are in another category. And then it's simply a matter of determining how severe the problem is, how motivated the person is, whether psychotherapy should be used, whether pharmacological intervention should be used, whether both should be used, whether none of this should be used. But a lot of the decision making is like, what are the dimensions of treatment? So now the problem, again, as you can see with what I just told you, is if you make up your mind within the first few minutes, then the rest of the data gathering isn't really adding to differentiating the diagnosis. It's often adding to differentiating the treatment. But I would point out to you that the professions, especially psychology and psychiatry, have hurt themselves in courts by the way in which they have come in and often given such diametrically opposite opinions, and that is unfortunate, and certainly the courts are even now setting some limits on expert testimony. That is what they'll let you testify to because of these kinds of arguments. Now, there are also questions of validity. One is content validity. Does your interview have content validity? This means, are you able to evaluate all or most of the dimensions of a target problem that was presented? For example, if a person indicated to you that they're very anxious, were you able to determine that this is not just a temporary or a situational anxiety, but a more profound disturbance? And you want to know what is the duration and also the possible causes of this anxiety. So if you have a problem, and it really is the problem, then you want to be able to know its dimensions. Now, there's another important validity called predictive validity. And what this examines is, will the data that you gather enable you to say something about present and future behavior and the functioning of the individual that's being examined? In other words, can you, with the data you have, and this applies to interviews, applies to tests, can you make some predictions about the future? In other words, do you understand the course the person is likely to take if some intervention doesn't take place now? So the person comes in, you evaluate the person. If you accurately assess the problem, you accurately assess its dimensions, then is there something you could anticipate may happen, both positive and negative, and then can you intervene in such a way that you will allow the person to experience the positive? Now the next validity item is called concurrent validity. And this is not often applied to interviewing. It much more often refers to testing. And it means, would you obtain the same information whether you use, in testing it means whether you use one test or another test. In other words, if you're testing the person for defensiveness, if you use test A, are you likely to get a similar picture as you would with test B? So, in other words, have you been able to define what it is you're trying to understand in this person, and will the assessment that you do or the testing you do allow you to understand that problem? Now the next we call criterion validity. By the way, all of these are described in your text. So now in an interview, this refers to whether the information you gathered correlates meaningfully with the problems the person actually presents. An example might be a person presents as a compulsive shoplifter. And the question becomes, now, is that the person's real problem? That is, should we focus on shoplifting, or do we find out in the course of our examining the person that this is somebody who really needs attention, and it's getting caught, and the shoplifting may be very complex. For instance, it may be that it is a woman who shoplifts very nice clothes. And the reason she shoplifts the clothes is so she can always appear very nice because she is trying to gain acceptance. The real problem is her self-concept. The real problem is that she feels terrible about herself and she's trying to seek attention. One of the ways is to dress in a way that her budget might not allow. And so if you focus on the shoplifting, that's probably an unimportant symptom. Focusing on her need to appear in a certain way becomes the real issue. In other words, that's really the criterion issue. Then there is a validity we call construct validity. This refers to whether an assessment is systematically related to the construct it's supposed to measure. So for example, if a person is anxious but improves, would your second interview be able to tell you that that had occurred? In testing, for example, the term construct validity means that if you gave the same test of anxiety to this person when the person first came in, and then you give it at a later date, their scores would reflect that their anxiety had changed. And if they had improved, their scores would show that the anxiety had lessened. Now, all of these, by the way, you may have hopefully studied all of these when you were taking courses in statistics, because these various forms of reliability and validity are important when you're testing, when you're interviewing, in the sense that you do want to be able to gather information that's not just idiosyncratic to you as an interviewer. You want to be able to gather information that you can convey to others often, because many times you do an assessment, you're doing it for others, and you want this to be a reliable and valid report. There are other factors, though, that come in. There are clinician-specific factors, and these really represent rather a vague, even though it's an important concept. That is the interviewer or evaluator himself or herself. There are some clinicians who are especially intuitive in determining if a person who does not appear especially depressed, for example, is suicidal. I mean, some people are able to pick up very clearly because they seem to have an antenna almost for recognizing what we might call soft symptoms, and recognizing that this person is far more troubled than they appear on the surface. Same is true for people who might be close to a psychotic episode. Sometimes when people come in, they've gotten themselves together. They seem very much, I want to say very much, they seem under control. Some people pick up right away that this person is using all of their energy to keep themselves together, and that you want to be very careful about this very fragile person. And especially, you do not want to do anything to start working on removing the person's defenses when they need every defense they have just to keep themselves functioning as they are now. And I remember when I was running outpatient services, there was a clinical social worker who had an amazing intuition to kind of pick up on these kinds of soft variables. And so when she saw someone, and often she got referred people who had presented before, we knew they had a past history of psychosis. They didn't look so bad this time, but she would pick up right away that the reason the person doesn't look so bad is that they are using up every bit of energy to keep themselves together. Now, the reason that's important, these clinician-specific variables are important, is, first of all, as we said earlier in this discussion, some people, because of their own interests, may take a certain line of questioning because they already have decided what they think the person's problem is. Another reason why clinician-specific factors are important is that the really good clinician understands that there are some areas you may not want to ask the person about in an initial interview because they're too frightened or they're too fragile to talk about those areas yet. And so if you're very sharp, sometimes you may come out with less concrete information. That is, you have asked this person nothing about their relationship with their mother, or you've asked this person nothing about their sexual life. And yet, almost, well, intuitively actually, but observationally, because you've seen this person and you see the amount of distress in them, you recognize you don't want to ask certain things right away. Terribly important variables. And as you can see, that if you make those decisions, then the information that you'll be able to put into a report is really going to be inferred, not direct information where you can say the client revealed this or that. And so one would assume this. Instead, you have to say, because of the way the client appeared, the way they handled the interview situation, etc., these are your conclusions about them. Now, we're going to take a look at diagnosing psychiatric disorders. This really is a very complex, sometimes troubling, and it's been an inexact process from its very beginning. I mean, we are in a period, and hopefully I'll be able to show this to you, but we're in a period where we are trying to improve how we diagnose people psychiatrically. Terms are thrown around all the time and have been for 50 or 60 years. But what these terms really mean, and whether if you examine the person or I examine the person, we would come up with the same diagnosis, is really troubling. Now, a great deal of effort has been expended to try to make these diagnoses accurate. But I would say, if we're going to be honest about today, we'd have to say that psychiatric diagnoses still remain a very inexact science. Now, the current manual, which is about this thick, it's a big book, called the Diagnostic and Statistical Manual of Mental Disorders, and you'll see it's DSM-4, so it's the 4th edition of this, and there's a TR attached to that, and I'll explain that in just a second. But this latest edition has updated, is not any different. The DSM-4 TR, for example, is not any different in terms of the actual factors that lead to a diagnosis than DSM-4. But they've put in a lot of information to tell you about each disorder, what its prevalence rates are, the onset, when it usually takes place, the course that often this disorder follows, if there are familial patterns, if culture plays a factor, age, gender, or if there are other things we have learned in our research since the last time we published this manual. Now, the DSM-4 was really published in 1994, so it's about 10 years old. And the I think the TR, which is this text revision, which has all the factors in I just mentioned, I think was published about 4 or 5 years later. Now, the very first diagnostic and statistical manual was published in 1952. So we have been working on this problem now for more than 50 years. And in diagnoses, if you think about it in a way, there are ways of categorizing people. That is, you say that this person is like a group of people that are in this category. So if we say, you know, a person is schizophrenic, they're like a group of people that who have a certain constellation of problems that we say can best be described by the term schizophrenia. Or we may say that we have a group of people who can best be described as having an eating disorder. Very different people. Or we may say these people can best be identified and treated if we give the label alcoholism to their problem. Now, what happened with the DSM was that it was developed in the United States, and it was developed for psychiatric disorders, and it didn't take long to realize that we needed to make some changes because there is the World Health Organization's international classification of diseases. It's called the ICD, the International Classification of Diseases. And if you're going to study problems worldwide, then you need some kind of system that everybody agrees on. So some changes were made, and a new DSM-2 was published in 1968. And let me just see if we have. I think I'm missing my. Let's see, maybe this. No. Just 1 second, and I'll see if Did I just miss this, Scott? Oh, thank you very much. Okay. When we have these diagnostic and statistical manual, and then we have a number after them. So here we have DSM-2. And as I say, this came out in 1968. That later there's a DSM-3, and then a DSM-3R. And DSM-3 came out in 1980. Then there was a revision, DSM-3R, in 1987. Now, the purpose of any diagnostic system is obviously to give us a reliable picture of the person that we're dealing with. But as I've been saying, you know, there are many problems. Each edition of the DSM, the Diagnostic and Statistical Manual, has tried to be more specific because research has consistently shown that the diagnoses of psychologists and psychiatrists are not reliable. That is, you have a group of us interview a person individually, we don't come up with the same diagnosis. A major problem in this is that, and you know, it's typical with scholars, the more we study phenomena, the more we subdivide the phenomena. So we come up with lots of categories. And we find that while these categories theoretically make a lot of sense, so that we say someone is an obsessive compulsive, in DSM-2 we might have said someone is an obsessive compulsive neurotic, and that person is different from a depressive neurotic, who is different from an anxiety neurotic, who is different from any other passive dependent personality, etc. Well, it's interesting. If you read the descriptions, you would say to yourself, yeah, I mean, I can see that. This one description certainly is different than another description. But when you get a person in a room and you have them talk about themselves, you find that you usually don't get these clear-cut kinds of people. That is, people tend to be complex when they come in. People have depression, but they also have anxiety. Some people are compulsive at the same time. Some people drink a lot. Is it to excess? Maybe. Is that their main problem? Maybe. Maybe not. And so when you start looking for the right descriptor for the person, often that becomes a problem. And what we have found is different clinicians tend to favor certain diagnoses over other diagnoses. Or they perhaps even they interview with a bias that allows them to get a picture of the person that they think will be an accurate picture. Now, it's these subcategories that are the problem. For example, clinicians are reasonably reliable in being able to diagnose, say, schizophrenia. After all, when people come in and the diagnosis of schizophrenia is made, it's not uncommon that the person is having certain hallucinations and delusions, and they have a certain fragile personality style. And if you can rule out that these have not been caused because the person has been taking some hallucinogenic drugs, or that they're in some kind of alcohol psychosis, you can come up with the diagnosis. However, once we start subdividing schizophrenics into various subcategories of schizophrenia, we do a very poor job. The studies show that really clinicians are not able to very well differentiate all of these subcategories. Similar statements can be made like for when we had personality disorders. There's probably a fairly good chance that a group of skilled clinicians will diagnose a person who has a personality disorder as having a personality disorder. But then, once you start differentiating, is this a schizoid personality, an obsessive compulsive personality, a narcissistic personality, a passive dependent personality, then we're not so good. In fact, we have lots of trouble. We fail to be able to put people in one of those categories where most of us put the person in the same category. And that's the serious problem with psychiatric diagnoses, is that in certain big groups, we are reasonably able to differentiate. That is, that the person has a personality disorder, doesn't have a psychosis. But when we start trying to be the scientists we all want to be, that is, we want to be more precise. We want to be able to give the person the label that is really most accurate. Then we have problems. And this, by the way, is one of the phenomenon that comes up in court testimony I was mentioning. You know, when one expert will say it's one way, one expert will say it's another way. Probably the best thing lawyers could do is challenge all diagnoses, because we're just not yet good enough. We haven't developed a system that tells accurately enough why a person is the way they are. Often, by the way, the interesting thing is empathically, you can have a real sense of what a person is like. That is, you can realize that this is a very fragile personality. You can realize this person is not psychotic. You can realize that this person needs to be dealt with very delicately. You can realize the person has very poor interpersonal relationships. You can realize the person is motivated but very frightened. You can realize that if any more stressors come into their life, they're kind of likely to be overwhelmed by anxiety. And you can develop a treatment plan for them, so that you can make a lot of important, astute observations about a person and develop an empathic understanding of the person. But 2 or 3 people who do that would not necessarily put the person in the same category. So it's these categories we haven't learned to use well yet. Now but as this process has gone on, that is, as we have tried to be more and more accurate, we have developed these new DSMs. That's why there's a DSM-2 followed by DSM-3 and then 3R and then 4. And all the time trying to become more accurate in describing these people. Now, we decided that back in 1980, when DSM-3 came out, that maybe just putting a label on a person is not good enough. And it doesn't seem to work anyway. We don't seem to agree a lot. Maybe we should use more descriptors. So we came out with a system that had 5 axes to them. And the first major axis the first axis was for major mental disorders. By the way, you can find this in page 95 of your book. They'll list all of these axes, but I'll just mention a few of them to you. For instance, on the first axis, you would put down disorders that are first usually diagnosed in infancy, childhood, or adolescence. The one thing you exclude in this group, by the way, is mental retardation. It comes later. But other disorders. Also, if you thought somebody had a mental condition due to a medical condition, you would put it here. Here, you diagnose things like substance abuse disorders and schizophrenia, mood disorders, eating disorders. There's a whole slew of things, sleep disorders, adjustment disorders. All those things fall in this category that we call DSM, or that we call Axis 1. Now then, there's Axis 2. Axis 2 contains developmental and personality disorders. Now under this category, so if someone is mentally retarded, you don't put anything on Axis 1. Instead, you diagnose their problem on Axis 2. Personality disorders are in Axis 2. And just to give you an example of how many categories, I've been saying, we keep trying to break things down, but you might be a paranoid personality disorder, perhaps a schizoid personality disorder, perhaps an antisocial personality disorder, a borderline personality disorder, a narcissistic personality disorder, an avoidant personality disorder, a dependent personality disorder, and that's only half of them. There is another group I won't go through, just give you the whole ritual, but you can see we keep trying to categorize people, and if you were to sit down and read the description of each of these, you would probably say, that I can see that. I can see an avoidant personality disorder. I can see this obsessive personality disorder. I can see this dependent personality. I can see this narcissistic personality is different. But when you actually talk to a real human being and they tell you about their life, it gets much more complex, and we really have not been able to solve that issue yet. Now, Axis 3 lists physical disorders or conditions that might relate to a person's mental disorder. And you do get things that are important. Certainly, I'd say the phenomenon of postpartum depression, which is a very serious problem that some women experience right after the birth of a child. I mean, you wouldn't want to just diagnose someone as having a serious depression without also making sure that people understand this person just had a child and the depression seems to have come after that event. So if you think that the problem the person has is related to some medical condition, then on Axis 3, you mention that. Now, then Axis 4 refers to psychosocial and environmental problems. It refers to stressors that people are experiencing. And at first, when this came out in DSM-3, we had a 6-point rating scale. And the 6-point rating scale rated the severity of recent psychosocial stressors that we think contributed to either the diagnosis you put on Axis 1 or the diagnosis on Axis 2. By the way, you could have put some diagnosis on both Axis 1 and Axis 2. But what you want to know is, are there stressors in this person's life that may be exacerbating this problem? And so we rated the stressors from very low to very high. It didn't take long for people to say, this doesn't seem to be terribly helpful. So by the time DSM-4 came out, we replaced this scale by just simply naming the specific stressors. So if the person had marital problems, we would simply list that as a current acute stressor. The person was having problems on the job, we might put, occupational stressors are a major factor for this person. Now, the kinds of things that you might put, those are fairly broad. If you want to get more specific, you might say the person's having problems with their primary support group, which might be their family, might be for someone in a university, people in a dorm, it might be for people who live at a club, people in the club, etc. Also, you would list things like if there are educational problems, which could mean lots of stress because of exams, occupational problems, the person's having housing problems, they can't pay their rent and they're being tossed out of their apartment, and that's causing a lot of stress. You want to know these things. Economic problems, someone's lost their job. If the person has difficulties because perhaps they have a physical illness, but they have no access to health care because they don't have any insurance. So you want to name psychosocial stressors, because if you may find that if you can reduce the psychosocial stressor, then these intense symptoms you're observing, which might be high anxiety or might be depression, etc., would change. And we do believe psychosocial stressors are very important. Now then, there is a fifth axis called Axis 5, and this lists the clinician's rating of the person's psychological, social, and occupational functioning during the past year. And this is called, we actually call this the Global Assessment of Functioning. And what we have these codes. So we start listing the person from, almost falling apart. That is, the person is having great difficulty. Whoop, excuse me. I'll give you an example here. In this particular assessment, by the way, the score, we give scores, or codes, but the lowest, we start with the lowest, that is the worst. And here's where you feel that a person has a persistent danger of seriously hurting himself or herself, or there's a real danger that they'll hurt others. Or they're so psychotic, for instance, that they have a persistent problem that they can't take care of their own personal hygiene. Or you would, rate this person very low if the person had a lot of suicidal ideation. Now, slightly up, but still very serious, you would rank the person, let's say that they have none of the things I just mentioned, but they do have, excuse me, delusions, or they have hallucinations. In other words, they have serious psychotic symptoms. Still higher, you would rate people who don't have those symptoms, but have moderate symptoms. They have flat affect, circumstantial speech. They really can't tell you much about themselves. They have moderate difficulty in social or school or occupational functioning. You list that, and to give people a picture of how is this person functioning right now. Then I'll just describe to you, if you got to the top of the scale says this person has superior functioning in a wide range of activities and a wide range of life's problems. Life's problems never seem to get out of hand. This person is sought out by others because of his or her many positive qualities, and the person has no symptoms. Now, the scale is used that way to show you go from, very significant deficits to very healthy functioning. Obviously, people who come for treatment don't get rated at the top when they first come. But you can have somebody move up the scale. That is, you can have somebody, when you rate them, their global functioning, you can find that, and especially if you think about this, of course, on axis 4, we talked about these stressors. Well, if you're able to reduce some of those stressors, then you may find that on your global assessment of functioning, the person is going to be ranked higher. Now, I have certainly emphasized to you greatly in this presentation that we have improved this over time, and yet we still have many problems. And one reason why there are some problems is that when you take a symptom approach to people, that is, we want to look and see the person anxious, the person compulsive, the person depressed, is the person manic-y, that we do know that people with similar symptoms do not necessarily have the same problem. In fact, they may have quite a different disorder. For example, an individual who is very depressed may be so for some very complex reasons. And depression might definitely be diagnosed as the problem. I mean, you look at the person, they're depressed, they meet all these criteria that we have for depression. We diagnose them as being depressed. Now, there are other people who are quite depressed. And the symptom serves as a defense against a more profound problem, perhaps against a psychosis. So what happens when you examine someone is you may realize that this person has a symptom, and we should alleviate it. That is, we should either do psychotherapy with this person's depression, we should give the person antidepressant medication, maybe we should do both, and that would be the best approach. However, if this very serious depression is masking something even worse, like a psychosis, you want to be very, very careful as to whether you start immediately treating the depression. Now you may be saying, what does he mean by masking? Well, there are some people who really are very close to being psychotic. Anxiety is overwhelming them. And what they do is they simply get depressed as a way of protecting themselves from becoming even more primitive. If you start off not understanding that, and you try to get the person to be less depressed, what you will find is often the person then is less depressed, but they're more disturbed, because then what you see is that person is delusional, the person has become psychotic, the person is in even worse shape than they were before. Had you allowed them to stay depressed and very gently worked with them, you would have realized that this person actually is psychotic, and that you want to start working with helping them to develop a relationship with you, and you want to allow them to stay depressed as long as they need to stay depressed until you understand better what really is this individual's problem. Now, this phenomena happens frequently, too frequently. And in our next lecture, I'm going to point out to you some of the unfortunate consequences that happen when one is too quick to focus only on symptoms, and one doesn't understand the deeper meaning of the symptoms and the more profound difficulty that someone is struggling with. And as a result, the extreme, of course, is that sometimes people take their lives because of these mistakes. But we'll start our next lecture just talking about that phenomena. Now we'll take a break.